without further ado, please welcome Dr. Bleistein.
Thank you. Great. Oh, that's easy. Hi, thank you so much. That is quite a talk to follow, but hopefully I can be interesting after that. I want to talk to everyone about how to understand and recognize eating disorders in practice. And so first I'm going to introduce you to a wonderful woman who came to me a few years ago. Her primary care doc had referred her for bariatric surgery, and she didn't want to have bariatric surgery. So she came to see me in my multidisciplinary medical weight loss practice. When she came to me, she weighed 425 pounds. She had a BMI of 63 and really had a lifelong struggle with her weight. Interestingly, she wasn't terribly sick with her obesity. So I don't know, how many of you clinicians out there use the Edmonton obesity screening or staging scale in your patients? No, and that's interesting. So rather than using BMI to decide how sick patients are, what the risk is around obesity, we use something called the Edmonton Obesity Staging Scale, which really looks at the burden of the obesity on metabolic disease. And so for this patient, she was actually stage 2 out of 4. She had some reflux. She had mild elevations in blood sugars for those of you who recognize a hemoglobin A1C of 5.9 when I first saw her. She was on a very low dose of lisinopril for some mild hypertension. She never smoked or used alcohol. She wasn't exercising regularly when I first saw her, but had this kind of picture. And so I started to ask her kind of deeper questions about what's going on with you. And when you see patients, you maybe should be asking them, have you ever had episodes where you felt out of control with your eating or where you ate until you were overfull? And sure enough, she had. And I said, well, how often is this happening? And she said 2 or 3 times a week. It was a significant problem for her. And I said, how do you feel after these episodes? And she felt a lot of shame and a lot of regret and a lot of guilt. And it really impacted her, her life greatly. If we think about this patient who's 45 years old when she's coming to me, she was referred for bariatric surgery. She never knew that she had an eating disorder. She never knew. So she actually was diagnosed with binge eating disorder. I have a certified eating disorder specialist in my practice who helped diagnose her. And when we look back at her history, as Dr. Palmer talked about, she had significant history of adverse childhood experiences. I do an ACEs screening on all my patients, and she had 4 or 5 of those were positive and a significant history of trauma. And so all of that kind of contributed to this, her struggle and her lifelong struggle with weight and health. What I'd like to do as we talk about this is really introduce or talk to you a little bit about eating disorders so you understand them. And I'm going to jump pretty quickly to talk about binge eating disorder because that's what I see mostly in practice. But truthfully, what I really would like for you to get from this talk is that eating disorders, and especially binge eating disorder, are much more common than we may be aware. And if we don't ask the question, we won't know. There's a lot of shame associated with disordered eating and eating disorders, and patients don't come and tell you. You have to ask. And the other thing that's important is that some restrictive plans that we might put patients on actually could exacerbate this condition. If we're not aware of it, we really could make things worse. So when we think about eating disorders, they're first and foremost a psychiatric disorder, psychiatric disease. And they really are marked by severe and persistent, irregular or abnormal eating habits. And they're associated with emotional distress. So that's really a key feature of all eating disorders is the emotional distress component. And they really are all associated with a preoccupation with food, weight, and body shape or size. It's an overvaluation of body shape and size. So that's what we see in all of them. If we look at the DSM-5, which is sort of the Bible of psychiatric disorders, they define 5 different eating disorders. So anorexia nervosa, bulimia nervosa, there's this sort of junk pile of eating disorders, if you will. That's called other specified feeding and eating disorders, or OSFED, avoidant restrictive food intake disorder, and then binge eating disorder. And when you get the copy of the slides, I've summarized the details of all of these eating disorders, so you'll have that information, but I'm gonna switch gears and really talk about binge eating disorder now. And when we look at binge eating disorder, it really starts with that overvaluation of body shape and size, but it's associated with, with a dysregulation of emotions and a difficulty dealing with negative feelings, oftentimes associated with low self-esteem as well. And so patients with these strong negative emotions will turn as a coping mechanism to restriction or control of their eating. And sometimes then with increased stressors, something happens, maybe another traumatic event, they're unable to really meet that restriction, and the rules become a little bit too hard, or a lot too hard, and they'll end up with a binge eating episode. And what happens with this is the patients may, in just a short period of time, so less than 2 hours, will eat excessive amounts of food, and we're talking 2,000, 3,000, 4,000 calories or more in a sitting, and just have this sense of loss of control, around their eating. And then when the binge episode happens, they have a sense of failure. They have that sense of shame. It increases the stress and the distress from the negative emotions, and the cycle starts again. So we see this again and again. So this talks a little bit about, what happens. What this looks like in patients is that they tend to eat really rapidly. They'll eat until they feel uncomfortably full. But that negative feeling afterwards, that emotional distress, they feel disgusted with themselves, they feel depressed, they feel guilty. And again, that shame piece, they aren't going to be forthcoming that they have these behaviors. And most of them don't recognize this as an eating disorder. They think there's something wrong with them. They feel that they failed in some way. And with binge eating disorder, when we define it, there's an absence of compensatory behaviors. So bulimia nervosa looks very similar in terms of that cycle, but they then have compensatory behaviors of either, of purging or overexercise or that kind of thing. So when we look at this, it really is actually very common. It's the most common eating disorder that we see, and about 2 to 3% of the population as a whole would meet the criteria for binge eating disorder. It's also the most gender-neutral eating disorder, and so it's about equal in men and women, which is different from the other eating disorders, and there's no racial differences in prevalence of eating disorders. So patients who identify as Black, Indigenous, or people of color, are equally likely to have it, but they're less likely to seek treatment for it, and they're less likely to receive treatment for it. And in addition, they have what we call sub-threshold binge eating disorder. So they don't meet all those criteria that I showed on the previous slide, in terms of frequency, but they still have these behaviors. They still have the emotional distress that's associated with it. What's really important, especially in a crowd like this, where you may be seeing patients coming to you for, if you're a dietitian or a health coach or a physician, for weight loss and support losing weight, 30% of patients who are coming to see us for weight loss have binge eating disorder, and almost half of patients who go for bariatric surgery have binge eating disorder as well. So really common, and we should pay attention and be asking these questions, because these are the people who are coming to see us, right? As Dr. Palmer was describing earlier, trauma is really common in these patients. 82% of patients have had some form of adverse childhood trauma, and that might be emotional abuse, physical abuse, or sexual abuse. And, so it's just that trauma piece is so important to get that history and know and understand. Patients also, it's very heritable. So about 41% heritability in twin studies, and that's true of all the eating disorders. They have all been shown to have some genetic component to them as well. When we think about the neurobiology, we just had this great talk on neurobiology, with patients with binge eating disorder and obesity actually have a suppressed pleasure response to food in the reward pleasure system of the brain, compared to patients who just have obesity but don't have binge eating disorder. We also see decreased activity in the impulse control areas of the brain. So I'll talk a little bit later, but we see that impulsivity piece is common in some of the other mental disorders that we see with patients that have this. And there's a lot of other really interesting neurohormonal changes that are, in that hunger satiety pathway as well. Environmental and developmental factors are important, so food insecurity is actually highly associated with binge eating disorder. So I'd like to introduce you to another patient that I saw, and this patient was sent to me by her endocrinologist for difficult to control blood sugars and medical weight loss. And what was happening with this patient is her hemoglobin A1C, her sugars just kept going up, and they kept increasing her medications, giving her more and more medication. And then she would have hypoglycemic episodes, so her blood sugar would drop, but she was still having really high hemoglobin A1Cs. They couldn't figure out what was going on. So the patient came to see me in my clinic. And what's interesting is we look at that Edmonton Obesity Staging Scale, she was actually much sicker at a much lower weight than my previous patient. She had stage 3, she had diabetes with secondary complications of diabetic retinopathy. She had obstructive sleep apnea. She was on lots of medications. So I know these are not familiar to you, but this is a lot of medication for a type 2, patient with type 2 diabetes, hemoglobin A1C out of control. She was drinking tons of coffee. But she was actually exercising regularly. And when I got into the details of what was going on with her, she said, I never really feel hungry, but I also never feel full. She didn't have signals to tell her hungry or full or anything. It just wasn't there. And she had this very dissociative pattern of eating, that is, she just didn't recognize these signals at all. She was really triggered by visual cues, and it was interesting because she would tell me that she would actually go out purposefully to shop for binging foods and bring them back and would binge on them. She would go on trips with girlfriends and would stop in the airport to eat and to have a binge episode. It was just so controlling her life and ever present. And what was really interesting with this dissociative pattern of eating that she had is that she had to put hot sauce on everything. And so my dietitian sort of noticed this, and she said, I just put hot sauce on everything I eat, because she wasn't tasting food. She was just eating. And she also had significant adverse childhood experiences in her life. And so when we think about these, when we think about binge eating disorder, there are a lot of comorbid medical complications that we see with it. Certainly we can see obesity with it. Not everyone with binge eating disorder has obesity, right? And so that's not, you can have binge eating disorder and be in a normal weight as well, but it's very common to have obesity with it. But we see these other metabolic diseases are really significant and increased in patients with binge eating disorder, whether it's metabolic syndrome, dyslipidemia, diabetes, and like we saw with this patient, those out of control blood sugars that they couldn't figure out what's going on, why isn't she getting better? Sleep disturbance is really common in these patients, and so decreased sleep quality. Narcolepsy is actually more common in patients with binge eating disorder. And we see a lot of GI complaints as well. Patients have an increased risk of dysphagia or difficulty swallowing, reflux, they get abdominal pain. What's interesting is they have dysregulation of their hunger cues. Like this patient that we saw, she really didn't recognize fullness. She didn't notice hunger. She just didn't have, those senses weren't working properly. And so important to recognize if a patient has eating disorders, they're not going to do well with an intuitive eating plan, for example, because they don't have any intuition about it. Their signals are really disrupted. And patients with binge eating also have increased risk of fibromyalgia. So the next patient that I want you to meet is a woman who is, she's a young woman, professional woman in her 20s, BMI of 37. She had lost and gained weight, many, many times in her life, but she also had a history of ADHD and wasn't currently treated. She was exercising regularly with a trainer, but just struggling with weight loss. So I started to ask her more questions. One of the things we want to make sure and check with our patients is, what is your substance use history? Also something patients may not tell you unless you ask, right? So she doesn't smoke, but she was using marijuana nightly, and she was binge drinking 1 to 2 weekends a month. There we go. So the patients, then I get into that, do you ever have these loss of control eating episodes? And sure enough, she says, well, I eat a healthy breakfast, lunch, and dinner, but then I kind of overeat and I just start grazing, eating, again and again, lots of little episodes after 8 p.m. until she goes to bed. How do you feel about this? She had a lot of regret and shame, felt like a failure because of these behaviors, just felt really out of control. And again, never recognized this as an eating disorder. The other thing I asked, and it's important to ask, is do you ever purge after eating? Do you have purging episodes? Patients will not tell you this if you don't ask, but they're very forthcoming if you actually ask directly. And sure enough, she did have a remote history of purging. She was vomiting daily after binging episodes for about 2 years as a teenager, never diagnosed or treated. Never diagnosed or treated for it. So she did have binge eating disorder. She had symptoms of night eating syndrome, which is when you eat more than 25% of your calories after the evening meal at night. She didn't have that history of ACEs, but she did have a history of domestic violence and trauma with a recent relationship. So one of the other things we see very commonly with eating disorders is the association with other psychologic disorders. And so depression, anxiety, PTSD are really common. ADHD is really common, and that's that impulsivity piece, right? Decreased control around impulsive behaviors. So it's commonly associated. And of course the PTSD, that trauma piece, is very common. So how, to recognize eating disorders, when should we screen patients? And I would say always. Right? If 30% of the patients who walk in my door are likely to have binge eating disorder, I am doing a disservice to them if I'm not asking everybody, do you have any of these symptoms or problems? Patients with obesity or patients who are really underweight, so BMI less than 19, you should really ask. And I would tell you, I can't tell you how many times I've talked to patients with anorexia or bulimia who've said, I lost 30 pounds in 3 months and went back and my doctor just praised me up and down. Look what you did, you lost all this weight, that's fantastic. And meanwhile, I was taking a box of laxatives every day to achieve this, right? So we need to ask and think about that. Not necessarily jump to praise, but tell me a little bit more. How did you do this, right? Think about it with those patients who are doing really well, but all of a sudden hit a plateau and say, hey, what's going on with your eating? Do you ever have loss of control eating episodes? And so the other thing that you want to do is, ask other questions around other types of eating disorders, right? So do you ever feel out of control with your eating? Do you ever eat till you're over full? But the other thing is thinking about, do you eat for over long periods of time, over several hours? So I talked about the patient who was grazing. So patients post-bariatric surgery, it's hard to eat 5,000 calories in a sitting after bariatric surgery. So patients with binge eating disorder after bariatric surgery will graze all day long. They'll just eat all day long. So important to ask those things as well. How do you feel after these episodes? How often is it occurring? And then these other kinds of questions. Are you eating in secret? Tell me about that. Tell me about your rules about foods or eating certain foods or eating. Some patients will cut up their food and they have this very ritualistic process of cutting up their food into smaller and smaller pieces, for example. Have you ever purged after eating? Really important to ask the question because they won't just tell you. Have you misused laxatives? Again, I've just been shocked at how people misuse these things. And if you don't ask, they won't tell you. And that's, those kinds of things, the misuse of laxatives, diuretics, those are the things that are fatal for these patients. And it's actually the leading cause of death from psychological disorders is eating disorders. And then tell me about your history of food restriction. So patients won't always tell you if you don't ask specifically, but I go for, I had a patient tell me the other day, I would just, in college, I would just not eat for 3 days when I needed to lose weight, and that's what I would do, and so at regular intervals. I've had patients come into me in residential care who would go 3 weeks with eating nothing. Nothing at all. So asking patients what's going on is so important. So the treatment for this, really key, the psychological support is so important. Coming up with a treatment plan, and so acceptance commitment therapy can be really helpful for patients. Cognitive behavioral therapy, dialectic behavioral therapy is really helpful. Supported exposure therapy can actually be really helpful. And that might be either around trauma, so you can do written supported exposure therapy around trauma episodes, but also with specific foods. And so I've worked with patients on, trigger foods that they have, and one patient very, struggled with pizza. And so she had just a supported exposure therapy with the therapist around eating pizza, and she ate a piece of pizza with the therapist, and suddenly it doesn't have the power in her life that it did. Nutritional plan is so important, having a structure, sit down at the table at a specific time, for a specific period of time, feet on the floor, don't be doing other things while you're eating. That's really important to have that structure. Medications can be really helpful for these patients as well. There's one FDA-approved medications, but I've found some other things that have worked also. And really close follow-up. Make sure that you're seeing these patients regularly as well. When we think about treatment, also, there's really a differential with binge eating disorder. So not all these patients look the same, and not all treatments are going to work for them effectively, the same way. So there's some patients who are really deprivation sensitive. And for those patients, restriction can be very triggering. So for example, in clinic, what you might see is the patient comes in, you have them on their diet, it's a really restrictive plan, you see them back the next time they're doing great, and maybe another time after that they're doing great, and they disappear. And they disappear because their binge eating was triggered, and then they're embarrassed, they have shame around coming back, right? And so really watching patients deprivation sensitive are not going to do well with really restrictive plans. Affect triggered or negative emotions, behavioral support, psychologic treatment makes a big difference for those patients. Addictive and dissociative type binge eating disorder, and I think the next speaker is going to talk a little bit about food addiction as well. Trauma work can be helpful. A lot of those patients have experienced trauma. The exposure response prevention therapy works well with them. And then for patients with opportunity or habitual eating, where they just get into this routine and these behaviors, having a very structured nutritional plan actually does well with those patients. So again, I just really would like people to take away from this that eating disorders, and especially binge eating disorder, is much more common than what we might be aware. And if we don't ask the question, we're not going to know. We just won't know. And there's some restrictive plans that we put out, that we put patients on that really could make the situation worse. It's so important to recognize an eating disorder in a patient before we start treatment to make sure that we treat them appropriately, effectively. We don't make things worse for them. If there are any questions, I don't know if I have time for questions or...